Okay, welcome everyone. Welcome to Grand Rounds 2023. You're all as excited as the Grand Round Committee that this has started, and we've got an exciting presenter for our inaugural session for 2023. Before we introduce Bart, our speaker, just wanted to give our our annual award for physician training excellence by clinical unit for the previous year, so for 2022. Unfortunately, our Director of Physician Training, Renee Esley, can't make it today. She's in clinic, but she's asked me to present on her behalf. This is actually the James D. Rosario Award, Memorial Award for teaching by clinical unit, and it's based on a combination of exam preparation teaching, mentoring, ward-based teaching, and sort of contributions across the board by many faculty. So I'm very happy to announce that the 2022 winner is the Neurology Department. And Raja could come and accept this award on behalf of the, maybe Bart can see as well. So we're handing out an award, yes. Thank you. Yeah, thanks. Thanks. So just neurology, this is the second time they've won the award, so 2019 and then 2022. So setting the bar very high for the rest of us. But thank you very much, Roger, for your support and the team's support of our trainees. Much appreciated. Okay, so to today's Grand Round. So we're very privileged to have a visiting presenter, Dr. Bartlomiej-Piechowski Jozwiak from the Cleveland Clinic in Abu Dhabi. So he's a Associate Professor of Medicine at the Cleveland Clinic. He's the Director of Research at Cleveland Clinic Abu Dhabi, and a staff physician at the Neurological Institute in the Cleveland Clinic over there. Previously trained in Poland, but it did his neurology training and fellowships in the United Kingdom. We're very excited because we're hoping Bart joins us later this year in a senior position in the neurology department. So Bart's going to be speaking today about electronic medical records and the use of big data as a predictive tool for cardiovascular outcomes. And this is particularly topical for us, given that we've just launched our DHR, and the system that Bart will be talking about that they've collected this data is also a Epic-based DHR system. So there will be lessons learned for us, and I guess opening the potential for what we can do from a research point of view, and then how is that clinically relevant. So thank you, Bart, for joining us. I'm going to open the floor to you now, and we'll pop up at the end if there's any questions. Can you hear us okay? Are you ready to go?
Yes, I can. Okay, so thank you very much, Ashwin, for this kind introduction and for inviting me to present our work. And also I'd like to thank Anna for organizing the Grand Rounds, and Nahum for his great help in logistics. And of course, the awardees and the Neurology Department for receiving the award. So without further ado, I will just quickly skip into my presentation. So this is the work that we did last year. And as Ashwin said, this is work based on electronic medical records. So I'll be talking about how we designed and why we designed the algorithm to predict outcomes, cardiovascular outcomes in our cohort of patients. So all of us, the recent years were new. We were operating in the reality we're not understanding that well for many reasons. The SARS-CoV pandemics came, we changed our stream of patients. It's changed the medicine we did because of paralyzing and shifting work pathways into helping hyperacute patients with respiratory infections. So it affected us also with the logistical issues, service organization, and affecting other hyperacute pathways. So it was a completely new reality. So estimation of risk in a completely new environment was very challenging. And while we speak about risk, of course, risk is one of the parameters that really helps us tailor and guide management of our patients. So My personal take on medicine is that I prefer to see a patient in my clinic to prevent an event rather to hear an ambulance coming. So every hyperacute stroke coming, from my perspective, is an opportunity lost, because these people dwell in the community, the risk builds up in the background, and we are not seeing it. And this is very unfortunate, because considering the technological capacities we currently have. So we all know that the prevalence and incidence of cardiovascular disease has been increasing over years, and also the related case fatality and mortality. So cardiovascular disease has its individual impact, societal impact, and puts a lot of pressure on the healthcare resources. There are established cardiovascular risk factors. We know them very well. They haven't changed in a way. However, they may change in the ranks. So you can see here on this graph the 1990 rank and 2019 rank. So one of the changes that you can see is that, for example, high body mass index comes into play, and tobacco smoking was a bit degraded. These are well-established risk factors. They are all, in a way, preventable, but we can't change them in a way. So by itself, hypertension is a disease already. Same applies to hypercholesterolemia and other parameters here. I would like to draw your attention to air pollution, which sits there as the fourth risk factor for cardiovascular disease. So this is the environmental aspect. We have many scales that you're very familiar with, and my apologies about this very busy slide. My intention was not to draw attention to great details, but just to list the most famous and mostly used primary risk assessment scales. You can see them listed on the left-hand side here. So there are many, they are well established. The time frame that they predict the risk for is from 5 to 10 years. And if you know, for example, Framingham project, the study in Framingham was done a few decades ago. So the risk factors, the population structure, the medical interventions for now, for the third millennium, this is already, we can say, obsolete. They are very valid studies, however, and scales. However, can we apply them to the third millennium population? So when we look at risk, we of course divide subjects into different risk levels. So if the estimated 10-year cardiovascular risk is below 5%, it's low, then you have 5 to 7.5 with a borderline risk, then intermediate risk 7.5 to 20, and high risk above 20. So if we identify these people with the current tools and allocate them to any of these risk categories, it of course necessitates further steps of their management. This would be lifestyle suggestions, early medicated prevention, and then more intensive investigations in cardiac patients, cardiac calcium score, IMT measurements. So many diagnostic tools and many preventative strategies we can use to these patients, this risk subgroups. So now when we use the scales to assess an individual, on this graph here, you can see this horizontal line depicts 10 standard patients with different risk levels. And on this line, on the vertical line, you can see the percentage of risk. So for each individual patient using these scales, you have a split of risk estimates. So in patient number 1, you have the risk that splits from 50 to 100%. So this is a huge split. You can see across other model patients, the risk is not adequately predicted with these tools. So most of these risk assessment tools were developed in Europe and the United States Do they apply to individual country level populations? Like, for example, the country that I'm operating now within the United Arab Emirates. So when you look at the population structure in the UAE, it's very particular because of almost 80% of expats. So it's 10 million population, 8 million expats, or even a bit more, and the rest are UAE nationals. So if you look at the population tree, you have females here, males on the right-hand side. You have this huge bump in the males in their third, fourth, fifth decades. These are workers, mostly blue-collar workers, coming from Southeast Asia. So when you want then to apply any risk estimation for this very ethnically mixed and age particular population, the scales may not be that adequate. And bear in mind, remember the previous slide when I showed you for model patients, how it was splitting in the Western world. So the scale that we used as the comparator here is the Q-RISK-3 score. Some of you may be familiar with this. Is a very robust score developed in the UK. This is the platform that you use here. You put all of the patient's parameters, and the scale is producing a 10-year risk estimate of cardiovascular diseases. So it's stroke, it's heart attack, and it's cardiovascular death. So this the scales that I mentioned before, you can see a few of them here. WHO MENA, SCORE H, PCREW, Framingham studies were applied to these very complex Emirati population. You can see on this slide here how the proportion of risk stratification distributed between these different scales in the Emirati population. So then on the next slide, you can see how the high risk Emirati cohort was assessed with these scales. The previous slide showed you overall population of patients is the high risk population. And you can see there is really a significant difference between percentage of patients considered at high risk. So can we use these scales to assess cardiovascular disease risk in the UAE population? So our objective was to develop and validate and also implement a risk assessment algorithm estimating 1 year risk of initial stroke or heart attack. The reason why we went to 1 year is there are two reasons for that. First of all, our hospital started operating in 2015. So until now we have, well, 8 years of electronic medical records with EPIC. So this is the data that we have. But also we wanted to focus on something that is really tangible in a sense that we can intervene based on our risk estimation immediately and give our patients like more immediate risk of cardiovascular disease. So we wanted to identify high-risk patients and also as a secondary aspect of this algorithm to identify high-risk factors retrospectively in our material. So I told you about Q-RISK-3 being our reference scale. So just in a nutshell, the scale was developed on almost 8 million patients and then validated on 3 million patients. And it's used predefined 30 predictor variables. The area and the curve, so the ability of the scale to predict the outcome was 0.88. Then the Q-RISK-3 was externally validated in Oxford in real-life samples. So then the AUC dropped to 0.7. In So the aspect of the QRISK-3 scores I told you is this using predefined variables. Yes. In our model, we opened the model to accept any data coming, raw data, no matter what. So we included approximately 5.5 thousand contemporary variables in our model. So QRISK score is using Cox regression and survival analysis, and we are using neural networks and linear modeling with random effects. So I told you that we're using raw data. So why we decide which information are we going to keep or bypass that? So forgive me my lack of mathematical and statistical skills to the level that may satisfy very deep analysis of that, but just wanted to say that the system was designed to keep the parameters which had more than 10% chance to be correlated to the outcome, not by chance but likely causation. So and then we also kept the parameter if the expected sample size of the individuals with this parameter will be big enough. So let's say COVID comes and we have 50 patients with COVID and 25 of them had a heart attack. So then the system is analyzing whether this is more than 10% chance that is not just an accidental correlation. And then second of all, do we have enough cases coming into our analysis to give this parameter green light to enter the system. So each patient in our model became their own control. So here you can see the patient timeline with all of the procedures and encounters from the very first moment the patient entered our electronic medical records. So this 5.5 thousand parameters, they refer to all of the visits, all of the diagnostic codes, all of the tests scheduled, all of the vital parameters. We excluded any numerical laboratory values because the system generated a lot of noise with this. So our prediction was not great with that. What I mean is that we look at the CBC done yes or no, or ECG done yes or no. We are not looking at the number of red blood cells or cholesterol levels. So it's test done yes, no, seen cardiology, been in the emergency, came 5 times to the hospital in a month, 10 emergency department visits. So this, you see the timeline, it unfolds here, and then you have the day, for example, 24 hours after admission for this particular patient, and you can then see the days split here with the time of the admission and all of the encounters and labs and orders and procedures, diagnosis, notes and medications dispensed to this patient. So until that moment here, the patient, it's their own control, and that moment defines all of the past for the system as valid. So in a sense, then the system needs to identify, do we see the parameters that we keep that are more than 10% of chance being related to the event? So it may be a bit complicated. I hope I explained this the right place for you. So our sample encompasses patients admitted from March 2015 to August 2021. We have almost 2 million total patient months, and the total number of patients is 350,000. So this 350,000 are all patients. The incidence of cardiovascular endpoints was around 2%. Yeah, so the model was trained on 280,000 patients and validated on 70,000 patients. And here you can see, yes, the number, the percentage of patients with the index event. So as I told you, we used quite a lot of data points. So 26 demographic codes, more than 34,000 diagnostic codes, any diagnosis, ICD-10 that the patient carried with them, entered the model. And again, if there was 10% estimation or more that this factor is not there by chance. It was included in the analysis. So 8,000 procedures, imaging codes, 900 chief complaints, 560 medication class codes. So it's not whether the patient was on atorvastatin or rosuvastatin, it was statin, yes or no. And then more than 3,000 lab codes, 4,000 flow sheet row type codes. Okay, moving on with this. The training data, I told you the split was 80% of the training and then 20% validation. So training data included 280,000 patients, 1.5 million patient months, and from the IT perspective, it required 100 gigabytes of hardware support. Validation of data included, of course, is 20%, so it's less of these patients, and approximately 26 gigabytes of data capacity. So we have an AI server for our research purposes only. So it's a small unit. I'll tell you about this later on, but just to tell you from the sort of operational perspective, that we use just one unit that was not connected to any clinical work. So this shows you a little bit the model, how the neural network prediction model worked. So we have the input layer here where all of the raw data comes into, and then you have hidden layers that do the analysis and probability estimation, and we have one output layer here. All right, so this is a repetition of the previous slide. So these are our results. So on this graph here, you can see the horizontal line is the probability of having a cardiovascular event, and you can see you should be seeing two colors here. So the pink, which you can see a very thin line here. These are individuals without the cardiovascular event. The blue color here shows all of the individuals with cardiovascular event. So you can very clearly see, this graph basically shows you how the model is able to separate the ones without the episode from those with the episode. So the split is very clear. So the pink color ends here really. So all of the rest are patients with cardiovascular risk. Of course, there will be some outliers, somewhere here, individuals without the cardiovascular outcome, but majority of those is pulled here. So from the statistical perspective, splitting those without risk and those with the risk was the key goal of this project. So our model allowed us to, our algorithm allowed us to have area under curve of 0.9 in comparison to Q-risk, which after validation was 0.7. And you can see here how, when adjusting the false positive rates, we were changing those. Still, with 5% of false positive rate, our sensitivity was 57% and Q-risk was 20. Of course, we're comparing Q-risk performance not on our sample, but we are comparing it to the validation of Q-risk, the previous data on that. And with our sensitivity here, with 20% false positive rate, our sensitivity is 86. And for this percentage of false positive rate, Q-risk sensitivity is 45%. So I told you that we were retrospectively then asking the system, okay, so show us the correlates that came up high as linked to the cardiovascular outcomes. So just list a few. Some of these may sound logical from the medical perspective, like liver cirrhosis or dementia, Graves' disease. Here you have the odds, how much these items were connected with the risk. cardiovascular outcomes in our sample. So liver cirrhosis is 2.6, dementia is 2, Graves' disease is 35, but look at the very wide confidence interval. So probably there were not that many individuals with that. Immunosuppression, antiphospholipid syndrome, again here, very wide confidence interval. Parathyroid neoplasms, epileptic syndrome. So, I mean, there are lots of those. We wanted to get some clinical sense what parameters were connected to high risk in our sample, because again, as I told you, the population is different based on their demographics, ethnicity, and everything. All right, so moving on, I wanted to tell you just very quickly about the logistics behind that, because there was quite a lot of work in that with planning and organizing that. So the resources that we utilize for that, it's 0.5 FTE over 6 months of my biostatistician. So I should have told you about the structure of our data team. So we have a small data institute supporting our organization. So I'm leading that. I have a biostatistician, 1 data scholar, and 2 data scribes. So 0.5 FTE was the biostatistician's work to develop the script, do the modeling, fit the model, test the model, and revise the model. So it was a quite laborious work behind that. As far as the equipment is concerned, we used the Lenovo workstation. Price-wise, it was not that expensive. I think it's important to understand that we were not using any cloud high-tech solutions from Google, NVIDIA. We used middle-range, small GPU unit. The price for that was around 100,000 Australian dollars. And we used our existing skills in the team, of course, with allocation of quite significant time. So I'm saying that to tell you that this is doable in any organization without having involvement from large industry players. We are not generating anything to sell outside. We are developing an algorithm that will work on our population, and it of course can work in any EPIC based environment. So when we transplant this algorithm to any EPIC based system based on our data, it will be able to estimate the risk, to learn new population, like for example, population of patients in ACT. This model would just need to have access to EMR, to EPIC, and just digest all of the parameters, as I showed you before, to come up with individual risk estimation. So specification of the unit, it's 800 gigabyte RAM. And I told you this is Lenovo, and we were using open source software to run that. So the message is it's simple, it can be done in-house, and it's not that much expensive. So the last thing I wanted to say is when we have an individual, what the system will offer us. So when we input all of this data in the system can do 2 things. One, it can give a percentage estimate of the cardiovascular risk within the year. And based on our most recent analysis, the best estimation we can give, the best and most accurate, is 0 to 3 months from now, and 3 to 6 months. So this is really exciting because this puts, well, it moves the ground under clinicians' feet, because what happens then if I have someone with high risk within 3 months? So this is, of course, a subject for another project, how we can then incorporate the risk estimation coming from our system into clinical practice. So moving into interventional project where we'll be allocating these people for primary preventative interventions within the multidisciplinary team of cardiology, neurology, internal medicine, and all of the parties involved. So the system can give you an exact percentage for 0, 3, 3 to 6, and 1 year. Also, we can try to stratify into minimal, intermediate, moderate, and high risk. It just all depends on our preference. Okay, so I told you about our biostatistician. So here you have Terence. He's smiling as always. This is his station, so that's where it all happens. So he has the coding going on 24/7 on his desk, and he does it from home. Of course, I'm telling him not to work over hours and weekends, but he's so excited about that project. So other people involved in this work was Emna, our pharmacy scholar, and Dr. Wasim, our clinical pharmacist. And this is our hospital. And just to tell you, because we developed this AI machine learning capacity, this was one of the parameters that helped us achieving the status of the smartest hospital in the region, based on the technology that we offer, and it was published in sort of lay press. So okay, I finish here. Thank you very much for your attention, and I'm here for you to answer any of your questions. Thank you so much.
These microphones. Thanks, Bart. So I can start. Yeah, so fantastic talk. You stepped us through that fairly complicated, coding, and how you got to this sort of machine learning in a very systematic way. So I think you brought the audience along with you. So we'll have some questions from the audience here. So we've just got some microphones, but we might just ask to see if there's any questions on the chat. Let's see if the online audience wants to write in the chat box, and then we'll have questions online. Well, I might just ask the first one. So yeah, that's all right. Okay. So Bart, just in terms of the data, so your Epic is attached to your, is it just hospital level data, or is it also connected to primary care? What's the health network that you're getting the data from?
Yeah, so this is a very good question, Ashwin. So the system here, we don't have primary care. The country doesn't have primary care, so it's all secondary and tertiary care together. So we have primary care sitting in our hospital, but it's skeletal. So people come based on their preference to see specialists straight away. So the hospital, most of the cares against secondary, tertiary care, very small primary and internal medicine. So the patients, the population of our patients is stable in a sense that this is the insured patients, Emirati nationals. They are entitled to care in our hospital. So I think 92% of our population is the Emirati nationals. The rest is expats. So we don't have data from the other hospitals, but still the population is stable. So we cover 1.8 million population out of 10 million of the national population. So these patients would be roaming through other healthcare providers based on their insurance. I'm not sure if it makes sense, but we don't have dear doctors, general practitioners sitting in the community referring to us. So we may be the first stop and the last stop for the patient, or they may be moving into other hospitals. So in that sense, our data is somehow representative for the eligible population, but with a very different data, with a very different healthcare model, because it's specialist care model, it's not primary care model. The government is developing the primary care aspects of care as we speak, but it's really not perceived as of interest to the local population. They want to see a good doctor from a foreign good doctor. That's how the population sees healthcare. Of course, we're trying to change that. But just in a nutshell, this is our EMR data from our hospital.
And just to paraphrase your findings, so the raw data suggests that you can predict a heart attack or a myocardial infarct within 1 year at 90% accuracy. The sensitivity tool.
Yes. Yeah, so it's heart attack, stroke, or cardiovascular death. So MACEs, let's put it that way, major adverse cardiovascular events. And the biggest accuracy is 3 months, 3 to 6 months. And of course, within the overall is 0. Yes, it's 90%, really, yeah. Mm-hmm.
I've got a question from Professor Pavley.
Hi. I'm sorry, I came a bit late. The education discussed in the I guess one of the major problems we have is the operative assessment of cardiovascular risk. How would this work in that setting? So you've got a patient who needs something simple like a colonoscopy or cholecystectomy or a bowel resection. How would this stand up, or is this future research?
So, Bart, you want me to repeat that question?
Yes, could you please, because I couldn't hear it right. Yeah, thanks.
Sure. So Professor Pavley is a gastroenterologist. He's asking a question related to the use of this tool for perioperative or peri-procedural sort of risk assessment. So could this tool be useful in someone who's about to have a colonoscopy or elective theatre, and in terms of their perioperative management?
So this is a great question. So the answer is this tool can be used for anything you can imagine. So what you can change in the system, you just change your outcome. So you say cholecystectomy risk or, I don't know, hepatic failure, and you just put this as the outcome, and the algorithm will get all of the data in it and process that, and you have your individualized to your population, to your clinical criteria model. So this is the beauty of that. I mean, you can come up with anything. We are currently developing this for predicting medication errors. We are moving into assessing the bariatric surgery outcomes. So to estimate the risk of no benefit from bariatric surgery. So we just changed the clinical outcome. So this is not specific to the clinical domain or your ICD code that you're looking at. It's specific to the electronic medical records and the skills of your biostatistician that you can engage in developing the model. So that's the beauty of that, really.
A question from Dr. Das, a neurologist.
Hi, I'm neurologist. Now, in terms of prognosticating, let's say for strokes, we have data which say about the size of infarcts, the number of comorbidities, and the degree of deficits at admission. I'm talking about retrospective analysis and patients then doing well or not doing well. Many times families ask about the prognosis. Now, going back on retrospective data, looking at various parameters, inside of infarcts, as I said, comorbidities and medications used, can we have a model where we can sort of prognosticate the chances of recovery?
So if I understand the question well, you were asking about whether we can prognosticate the outcome based on the existing information, yes?
Correct. That's correct.
Yes, okay.
So an event has occurred, and then using retrospective data after the event has occurred to see how the prognosis of their recovery. Yes.
So again, great question. So this may, of course, this is doable because it will be forecasting. It will be forecasting. So we can say based on all of the available retrospective material in our system and this patient's clinical particularities, this is the probability of good or bad outcome. So this is forecasting. So At the business intelligence side, we are forecasting no-show rates in the clinic. So this is based on retrospective analysis, and we have forecast for all the operation OR utilization. We do it for both. So basically, we have retrospective data forecasting for the next, defined time period. So this model can be adjusted or developed to prognosticate the outcome, of course. And the more cases the model sees, the wiser it becomes. But the wisdom of the model needs to be specific to the local population. Because that's the difference, and that's the beauty of the model, because it tells you for the current population, current demographics, current healthcare arrangements that come as raw information in the system, this is your prediction. So if you move the model into another realm, the model will need to relearn all of these relations, and as I showed before, with the 10% cutoff of chance or no chance to be connected to the outcome, the model will be sieving through the input layer all of this information. So again, the sky is the limit here. We can plan for anything. I was considering also developing a model of the immediate outcomes, for example, of the TPA pathway as the patient comes in. As the pathway goes on, we have the door-to-needle time, we have the initial NIH, we have the onset to door times, all of this, and imaging parameters that this could be feeding directly into the model, and we could have like an immediate assessment whether this patient will need TPA, whether this patient is at risk of hemorrhagic transformation, thrombectomy outcomes, and all of this. Again, it all depends on your clinical question and also integrity of the data in the system. I should have told you that one of the main problems that we faced was that in EPIC, data sits in different data lakes. So numeric lab data sits in one lake, imaging, PACS, pixelated images sit in another. So this model was not looking at images with pixels, it was looking whether CT was done, not done, coronary artery calcium score done, not done. So we are not going into any pixels or images, but we discovered the lessons learned that if you want to do this type of projects, going deeper into available information, patient information in the system, we need to integrate the data sources.
Thank you very much for the talk. I'm Nicole, I'm a medical oncologist. I'm just kind of interested, you were saying that obviously the hospital runs the data, and I'm just wondering with this incredible prediction models, whether private health funds are going to try to get involved. I mean, if you can predict with that sensitivity, cardiovascular disease in 12 months, is there any concern? Have you had any concerns about patient confidentiality, or whether they want their data to be contributing to models, and concern about private health funds potentially? The colleagues said to me in 6 months because they say, well, you're about to have a heart attack. So
yeah, so this is a very valid question. This is the implementation part of this. So at this moment, this project is running on, of course, on the EMR. The data is not shared outside, and this is not a research. This is not a research project for the, I would say, at an individual level. I would say this is clinical improvement model. So we are not sharing anonymized information. There's no violation of patient confidentiality. Now, moving on into the clinical utilization, we have a risk stratification model embedded in EPIC. So the utilization side of this would be that when you sit in front of your screen, you log into EPIC, and you can have an information coming that patient X is at risk as per the model. So, of course, developing the system, the clinical application further, we may need to inform patients about this model being run, but we currently have a colon cancer model based on retrospective scales or breast cancer risk. models operating in EPIC. And again, these are retrospective models based on established scales. We have Framingham and Q-risk embedded in our system. So this works now, and we are not consenting patients for these models to be used. Also, the ICU deterioration models are up and running 24/7. So this is clinical usage of those. So I don't see any confidentiality, significant confidentiality concerns at that stage. Now, if we move into you mentioned the cholecystectomy, this wouldn't be any different. A physician sits with the patient in front of the screen, and we are discussing what's your risk based on your profile. So I don't think this would be requiring any specific confidentiality arrangements. However, the interpretation and of this information and guiding your clinical decisions, this may require some longitudinal setup, and the patient's agreeing, okay, based on my risk estimate, you're proposing X and Y, but this is not standard of care, yes, in this particular case. So if I say that you have high risk within the next 3 months, I need to consent the patient for the intervention, because we need to then collect outcomes to understand whether our model, first of all, is rightly predicting the outcome, and second of all, whether our intervention is able to basically revert that risk. So there are two aspects. One is the implementation and really using this model in clinical care, and this would require a consenting and the right setup. But just for theoretical modeling, there's no danger to PHI here. I hope I answered your question.
Yes, thank you.
Fantastic, Bart. We've run out to the maximum time now, so we might just call it to a close. So thank you so much for taking out your morning to present this case to us. This is fascinating, I think, and we're all seeing the potential that this type of research has for our institution, given we've come on board with a DHR such as EPIC. I've been playing around with ChatGPT a bit online, the AI interface, and I wonder whether we need to see a neurologist of the future. You just have to ask ChatGPT, and it interfaces with our database, and what's your own? Maybe that's the way of the future. Well, look, thanks very much, Bart. I really appreciate it. Can we just give a round of applause to Bart? Thanks very much. There is lunch outside.
Thank you so much. Thank you so much. Thank you for the invitation.